lipoprotein little a and atherogenic risk. Lipoprotein little a is a well-recognized independent risk factor for atherosclerotic cardiovascular disease. Epidemiological studies have indicated that about 20% of the population have elevated LPA. Mendelian randomization studies repeatedly emphasize that lifelong exposure to elevated LPA levels strongly and causally associated with an increased risk of ASCVD. Lipoprotein little a pushes patients for an atherosclerotic cardiovascular disease. The risk is almost same as that being experienced by people with heterozygous familial hypercholesterolemia. It is now recognized that extremely higher levels of lipoprotein little a may represent a new inherited lipid disorder. This is my case report which I had encountered in my clinical practice. 30-year-old gentleman, Mr. M, smoker for 10 years, had lost his father at the age of 50 years due to sudden cardiac arrest. His lipid parameters are not known to my patient. Mr. M developed STEMI, currently is in the post-PTCA status. His baseline LDL cholesterol was 176. I put him on Rosua 40. At the end of 4 weeks, it touched 152. Later, I added ezetimibe 10 milligram and wanted him to come back after 4 weeks. When he came after 6 weeks, the levels were only 128. But next time, he did not come on after 4 weeks, but he reported only after 8 weeks, telling me that he had developed another event, that is an ischemic stroke. So what has made this fellow to get into another problem of an ASCVD over and above the myocardial infarction which he suffered? So that tempted me to think in terms of an associated lipid abnormality, for which I submitted him for the lipoprotein little a analysis, which revealed that it was about 180 milligrams. Having seen this, let me now try to take you to the level of understanding of lipoprotein little a. It is a small LDL particle, LDL-like particle with an ApoB, which is closely attached to the ApoA by a disulfide bond. The LDL particle is responsible for accumulation of cholesterol in the vessels, and the inflammation is triggered by oxidized phospholipids. On the other side, when you have an ApoA, moiety, this is responsible because of its structure, which is almost simulates that of the plasminogen, is responsible for the fibrinolysis inhibition. At the site of plaque rupture and at the turbulent flow, it is responsible for myocardial infarction as well as ischemic stroke and atherosclerotic stenosis. This is the most important slide which I thought I should tell you. There are 3 important mechanisms, pathological conditions, which are probably responsible for increasing the atherogenicity of LPA. One is pro-atherogenic effect, foam cell formation, smooth muscle cell proliferation, adhesion molecule production, that through ApoB. Through ApoA, it is responsible for prothrombotic effects like decreased plasminogen activation, tissue factor pathway inhibition activity, increased platelet activation. The last one is the pro-inflammatory effects mediated by the oxidized phospholipids, responsible for an increase in the IL-6, TNF-alpha, high-sensitive CRP. Now let me now try to take you to our level of understanding about the link between the lipoprotein little a and the cardiovascular disease. There are 2 important landmark studies, population-based studies. One is Copenhagen's City Heart Study. The other one is the Copenhagen General Population Study. Copenhagen City Heart Study, which had evaluated about 11,000 participants with a 26 years follow-up. The next study is about 100,000 participants with a 14 years follow-up study, which had clearly indicated the cumulative incidence of myocardial infarction is going up between 85 to 120 milligrams of lipoprotein little a, starting from 90th to 95th percentile. It is also seen those patients who developed recurrence of events. In about 2,527 patients who developed recurrence of events, it is clearly established that more than 100 milligrams of lipoprotein little a is responsible for an increasing levels of MACE following this ASCVD. The hazard ratio is about 2.07. It is also seen that not only the morbidity but also the mortality is on the higher side. Cardiovascular mortality is on the higher side. The all-cause mortality is higher side beyond 90th and 95th percentile of LPA increase. It is independent of age, independent of gender, smoking, body mass index, hypertension, total cholesterol, and LDL cholesterol. There is also a mention about the link between lipoprotein little a and the valvular aortic stenosis. emphasized in this New England Journal of Medicine, which got published in the year 2013. There is a meta-analysis of Jiva study, which indicate about 7,000 individuals with aortic valve CT scans implicating the lipoprotein gene. It is also published in JACC in the year 2014, indicating LPA levels of more than 90th percentile in predicts about 2 to 3-fold increase of valvular aortic stenosis. What about the link between LPA and the ischemic stroke? There's a good study. Observational analysis revealed 1.20 hazard ratio, almost comparable to that of the genetic causal analysis. It is also seen in the EPIC Norfolk prospective study that the LPA has a link with an increased peripheral arterial disease. 2.7-fold increase in 19,000 participants had indicated that about 37% increase in the risk of PAD, not modified by LDL cholesterol values. So there is a problem with the mediation analysis which indicated that there is a link between LPA and heart failure also. Why should we get worried about LPA? Between the 90th percentile and 95th percentile, you have about 2 to 3-fold increase in myocardial infarction, 2 to 3-fold increase in aortic valve stenosis, and a PAD, increasing ischemic stroke, increase in heart failure, and of course the fatality is also increased. So ladies and gentlemen, we need to believe that it is a strong, independent, and likely causal risk factor for atherosclerotic cardiovascular disease. How to assess? Use well-validated assays, use isoform insensitive assays, fresh samples are preferred. What are the strategies to lower lipoprotein A? Statins have shown that there is an increase in the LPA levels. Probably the larger isoforms are increased and not the smaller isoforms. Niacin, no doubt it decreases the levels, but surprisingly there is no cardiovascular outcome data. CETP inhibitors, except the anacetrapib, all the other things had failed to show a reduction of LPA levels with the cardiovascular outcome data. PCSK9 inhibitor is the best drug to be used. About 25% reduction has been seen. Apheresis, about 35% reduction in LPA levels. ApoA1 antisense, nearly about 90% reduction has been witnessed. ApoA, small interfering RNA, olpasiran is a drug which has been tried, which has shown a decrease in LPA levels. Usage of the PCSK9 inhibitor emphasized in evolocumab, which was used in 4-year trial, and what is the outcome trial? This is about the LDL corrected value. How to arrive at the LDL corrected value? It is about LDL cholesterol minus 0.3 multiplied by the LPA mass. In our patient, it's about 60 milligram is the LPA, probably is responsible for the benefit which you can anticipate. The ODC outcome trial has shown that the baseline lipoprotein and the corrected LDL levels and their reduction by alirocumab predict the risk of MACE after recent ACS. LPA lowering by alirocumab is an independent contributor to the MACE reduction, which suggests that LPA should be an independent treatment target after acute coronary syndrome. Antisense drugs targeting RNA, this is a dose-finding trial. 20 milligram given every 6 weeks, 80% reduction has been appreciated. The conclusions of the phase 2 trial have shown that this achieved both primary endpoints and secondary endpoints, significantly reduced the LPA, significantly reduced the LDL, ApoB, oxidized phospholipids linked with ApoA and ApoB. 98% of the patients achieved the LPA levels of less than 50 milligram. However, we need to realize that there are no safety concerns at all by using this particular. Pelacarsen is, we are waiting to get the results published in 2024. Probably we may get some outcome data depending on whether it is 70 milligrams or 90 milligrams of LDL cholesterol, and above that we are going to get more cardiovascular benefit or more cardiovascular adverse effects. Lipoprotein in Indians, which has been studied by ENAS, higher LPA levels more than 30 milligrams was found about 25% of the Indians residing in the United States. A number of case control studies from India had repeatedly emphasized its link with CAD, MI, stroke, especially among younger people less than 45 years. Interheart study repeatedly mentioned about the population attributable risk is about 9.5% in South Asians when compared to Europeans. The recommendations by Lipid Association of India in 2020 is that initial screening of all patients for 18 years or so or earlier if there is a strong family history or a premature coronary artery disease. premature ASCVD occurring less than 55 years in men, familial hypercholesterolemia, a family history of premature coronary artery disease, recurrent ASCVD despite optimal lipid treatment, poor response to maximum lipid lowering therapy, ischemic stroke of uncertain etiology, calcific aortic valve stenosis. I think I am fully justified in requesting my patient to go for LP estimation as per this recommendation. Now, LPA should be considered as one of the important risk factors for atherosclerotic cardiovascular disease emphasized by Lipid Association of India. We have included one group called extreme risk group, where we have categorized into B, where a patient gets an additional problem over and above an ASCVD, another event occurring within a matter of 1 year or so, or a polyvascular disease as it is happening in my patient. Probably we should consider him as an extreme risk B category group, in whom you need to bring down the LDL cholesterol to less than 50 or less than 30, as the case may be. This is our patient's report. What am I supposed to do? This patient has got a positive family history, premature coronary artery disease, death, he suffered from myocardial infarction, he suffered from a stroke now, his LDL levels is high, still not reached the goal in spite of giving a high dose statin, LPA levels are high. What am I supposed to do? There is no target to only focusing attention on LPA. So all that we should do is to bring down the LDL further. Probably the drug of choice in my case is again PCSK9 inhibitor, for which my patient is not willing to take. Lipoprotein little a apheresis is probably one another drug which can be one another modality. This is a recent publication. About 5 days back it was published in New England Journal of Medicine. Small interfering RNA to reduce lipoprotein little in cardiovascular disease. Valpasturon, that's the drug which has been tried to reduce the lipoprotein little a. Ladies and gentlemen, let me conclude my talk. LPA is an independent risk factor for ASCVD, calcific aortic valve stenosis, stroke, PAD. Elevated levels probably increases the risk of heart failure too. Is it a missing link between premature and malignant ASCVD in Indians? The question begs answers from all of us. Lipoprotein little a should form a part of the lipid profile. PCSK9 inhibitors seem to probably confer benefit. Lipid apheresis is effective and expensive. Antisense oligonucleotide are promising CVOT results are eagerly awaited. So, lipoprotein little a is not little anymore. It is considered as a deadly cholesterol. Thank you very much, ladies and gentlemen, for patient listening.